Hi, welcome to Health 401, Health Policy and Governance. In video 1 for this lecture, we talked about governance and health governance and how the connection between the two fundamentally embeds human rights and community engagement as part of the discussion. In this section of the module's video, I want to talk about the role that each of those main 4 areas of governance looks like, and just go into a bit more depth and push us a bit further on those. So now I'm moving into each of these. I want you to think about the implementation activities in health systems and how diverse they can be, because we focus not only on prevention, but on protection and health promotion, about how we use knowledge and advocacy as part of governance to build capacity within a health system. This model of health governance is important because it helps us understand how we can do the business of creating good health and how we can engage in governance that supports that health. Another important aspect of implementation is to realize and think about who the implementers are. I think at the organizational level, this includes things like the ministries of health, public health agencies, health insurers, hospitals and clinics, patients and advocacy groups, medical licensing boards, and program evaluators. But these are situated within larger public policies around public sector effectiveness, finance, decentralization, public health policy and law, health and all policies, sector-specific policies. And they're all situated even broader in that kind of broader governance system of rule of law, democratization, peace and security, civic and accountability. For instance, if you were actually to go and look at things that impacted, say child mortality, and you were to look worldwide, oftentimes you'll find that the highest rates of child mortality are in those regions where you don't have rule of law, where you don't have peace and security. Places where civil wars are outbreaking are often the places where you see that low life expectancy and high mortality for young people. And it's important to recognize that that broader system also has a role in shaping the public sector and shaping the policies that develop, the beliefs around those policies, and in terms that works to shape how organizations act and respond. And so you can think of the role that society has to play, take for example, in the opioid public health emergency here in BC, right? If it weren't for the on-the-ground activism around these alarming rates of opiate deaths and opioid-related overdose deaths, then the Ministry of Health would be responding differently, public health agencies would be responding differently, hospitals and clinics and patient advocacy groups and medical licensing boards would all be responding differently. And so we have to think of governance as not just something that is done at the top, but that can be exercised and influenced at many different levels. And that's an important thing when we're considering what we're implementing and what we implement as part of health governance. In moving into accountability, there are important accountability relationships within health governance structures. Largely, the patient-provider relationship is an important thing to consider. There are generally 2 routes to think about accountability. There's the short route, patients going to providers, in which they basically have a bottom-up form of accountability. You can, if you don't like your doctor or you don't like the services you're getting, then you can just say, I'm going to go to another doctor. However, when the short route isn't available, then you have to go the long route. And that involves things like advocacy and activism to put pressures on governments to introduce regulations through health systems that can then impact and change providers. Some of this is about creating supply where there is no access. Some of this might be about creating policies that make sure doctors create inclusive environments and settings for their clients. Maybe it's about making certain policies universally available at multiple levels, such as accessing opiates or needle exchange. the health systems have the ability to affect that. And so that long route can allow you to work within health systems to affect providers and ensure that the accountability is focused on providing good health and good services. And so improving the short route, there are many strategies to do that. You can help local users become more effective monitors of providers. And so creating more engagement within the community and more awareness around important health issues. I think a good example of this is with a drug called pre-exposure prophylaxis. And it's an antiretroviral therapy that prevents HIV acquisition in HIV-negative folks. And this is importantly related to this idea of becoming effective monitors of providers, because the movement around pre-exposure prophylaxis has often been a patient going to a provider and educating their provider about this so that they could get a prescription. And so that helps improve choice and participation. This can be done both kind of in those informal settings, but we can also think about, with our licensing boards like the divisions of family practice and other, doctor and provider organizations. And we could think through how improving those systems to work together with doctors to improve understandings around sensitive issues, I think, is an important aspect of improving the short route. Improving the long route is what you might think of more typically as governance. That's including holding policy more accountable for services, making policymakers better positioned to influence the quality and coverage of services, making information more accessible, and improving supply side functions, meaning there's a supply of services that is accessible. And that's defining accessibility broadly, both in terms of geographic accessibility, financial accessibility, social accessibility, cultural accessibility, and so on. And so as you think about this, there's a quick question here to maybe test your little bit of knowledge on this short route, long route approach. So you can pause here and read through this, and then we'll continue on. The next aspect is civil engagement. Civil engagement is important in health governance, just as it's important in governance. I like to think of these 7 P's approach to thinking about who we mean when we say civil engagements. And I think it starts with principal actors. This includes things like health authorities, ministers of health, people who actually do, the policy making and decision making. But you also got to think about product manufacturers, pharmaceutical companies. You got to think about bringing in policymakers, people who actually design and write the policies, people who ultimately end up pay for it, so citizen opinion and citizen voice. And then purchasers, people who are going to get access to the drugs, get access to the interventions for places. Providers, that's doctors, that's community health settings. There's a big range of what we can think of as providers. And then, of course, there's the patients and communities themselves. That might be through engaging individual patients, or engaging a general survey of patients, or looking specifically to patient interest groups, because we recognize that all communities don't have the same health needs. And so being able to understand those specific needs of people who might need it most. So thinking about sexual and gender minorities and community-based organizations organized around HIV. We can think about indigenous health organizations, including the First Nations Health Authority, but also friendship centers around BC. And we can think of maybe organizations focused on aging, focused on youth, focused on people living in care homes, and how all of those individual stakeholders have an important voice to contribute. And making sure that you broadly engage the community will ensure that the policies and the procedures that are implemented, the way that you govern, is actually reflective of all those experiences, and therefore is most efficient in dealing with them. I also think it's important to think through community engagement and how we do that. So the CBRC, which is the Community-Based Research Center in Vancouver, has created this Grow and Lift set of recommendations. These were originally developed for conducting research within communities, but I think they have an important place to play also in community engagement and governance. To align goals, to focus on relationships, to make sure that there's open communication, to work to bridge capacity, and to make sure those communities are kind of there on the same page with policymakers and that you can align your goals together. Making sure that the language and culture is focused around anti-oppression, to make sure that it's accessible to Indigenous peoples, accessible to sexual and gender minorities, accessible to peoples of color, accessible to immigrants, and so on and so forth. We also initiate relationships early. We make sure that reports are given to communities first, and that this is all done at kind of the right time at the right place. I think when you start to think about community engagement in this way, as being predominantly relationship-based, coming together as equals, and working together, then that's when governance becomes a lot easier. Because all of a sudden, you go from a system of many competing interests, competing for maybe a common pool of resources, and you work together to identify what can be done to improve lives and improve health. And finally, I want to address human rights. Because as I said before, all of the other areas of public health governance rest on the basic assumption that you have human rights. And this is important to recognize, that we know that all people experience some form of oppression, some form of restriction of their rights. And this might be something very subtle in interaction, an experience of a microaggression in a healthcare setting. This might be something quite serious, like inability to get the care you need because of who you are. And so focusing on human rights is an important part of governance. And I think that's why we focus on things like social justice and health equity within public health. It's because we recognize fulfilling people's needs begins with an understanding of the basic dignity that people have. And that means that we meet their physiological needs by providing basic accommodation, by providing food, by providing water, by providing access to things like a safe drug supply, so that we can ensure that they're safe. But then it goes beyond that and focuses, well, it's also a right to be belonging and to be loved. It's also a right to have a sense of self and a sense of self-esteem and feel good about yourself. And it's also a right to be able to actualize your dreams and experiences. And so we think about what governance has a role to play in there. I think it highlights that health governance isn't just about health, but it's about happiness and wellness. And so taking a broad definition of what we think our role to be. When we think of human rights and health, I think there are lots of interesting examples to think through. Take, for example, this study that looked at heart disease in the United States. And it particularly compared white men and women against Indigenous men and women. And it looked and said, what is the relative risk of heart disease? Or what is the death rate of heart disease? And you see that generally, the Indigenous population has a much higher, notably higher level of heart disease rates and death rates. One significant one that I think is interesting is you look at the Southwest. And you see that in the Southwest, there's actually not much of a difference at all. And this is true also in the East, where actually white folks have a slightly higher death rate from heart disease. But in the Southwest, which is where I grew up, so I don't know so much about the East, but in the Southwest, we know that the Indigenous people there, many of them belong to the Navajos and the Navajo Nation, and that they are less exposed to your American people, to culture, to disease and language, and that this had to do with the fact that they lived in a dry and arid climate. It wasn't part of kind of the gold rush. It wasn't part of any sort of colonialization motive. And so they sort of lucked out. And so you can think how that system of having late colonial contact and how the colonial contact, once it did happen, happened in such a way that the Navajos were able to maintain their connection to the land. And you think about the effect that that might have on things like stress and family function and wellness, and how that big global setting of colonization, how that trickles down into an individual towards driving stress, how that could affect death rates and heart disease. That might not be the whole picture here, but I think it's important to consider when we think of human rights and health, we think about indigenous rights and health also. And so two of the reading assignments for this week are to read the United Nations Declaration on Indigenous Rights and on human rights generally. When I think about applying human rights to some of the most fundamental challenges that we face today, I think around issues like decriminalization of drugs. I think about issues around children and youth having the ability to self-advocate, both by participating in the political system, but also being able to access, services that kind of meet their needs with or without necessarily parental awareness. And I think if we take a human's rights lens on these issues, we get a much different focus than if we just focus on populations and making sure that the health system works well and that sort of thing. If we forget about the individuals in these stories and the individuals in these health systems, then I think you can often make the mistake of achieving an answer to a policy question that ends up hurting people on the ground. And this really comes down to a debate around utilitarian versus Rawlsian philosophy. Now, these are concepts that you won't necessarily need to know for this lecture, but utilitarianism basically looks at a population health issue and says, what is good for the most people? What will maximize the goodness, what it calls utility, which includes like economic utility, happiness utility, and other forms of social utility. So what will work the best just for the most people? When you take that focus, what works best for the most people, you can often forget what it's like to be the person who it is not working for. And human rights focus makes sure that we continue to focus not just on what's good for the most people, but specific community needs, looking what's good for youth, what's good for indigenous peoples, what's good for sexual and gender minorities, what's good for aging people in a care home who've been forgotten about, and that maybe don't have enough staff at their facility to meet their needs. And so thinking through that full spectrum of public health and social policy and how that intersects with individual human rights, I think has to be an essential function of what we think of when we think of health governance. So as I said, these are two readings that I recommend that you do: the United Nations Universal Declaration of Human Rights and the United Nations Declaration on the Rights of Indigenous People. I want you to go through these, and you can use these two multiple choice questions as kind of a guide. And then I want you to also think, are there any rights that you feel are missing from the documents? And you can identify one in the discussion board titled Emergent and Developing Rights. If you can't identify one, you can just comment on one of the rights shared by your classmates. And I think that would be a good way for you to engage and maybe think a little bit more deeply about this interaction between human rights and then maybe broader social policy and health policy concerns, and how really we need to start incorporating those two ideas is not competing, but is part of the same picture to a bigger whole.